Welcome to the Hot Topics webinar titled, What to Do When There is a CDI Outbreak. I'm Shylettera Davis, Nursing Home Program Manager for Health Insight Utah. I'm joined today by two guest speakers, Maureen Vowles from the Utah Department of Health and Lisa Pearson from South Davis Community Hospital. Maureen Vowles is an epidemiologist at the Department of Health, and Lisa Pearson is a registered nurse that oversees the facility's infection prevention program. Please join me in welcoming them as they share this information with you today. Maureen and Lisa, please take it away.
What is an outbreak? The Utah Communicable Disease Rule defines an outbreak as the increased occurrence of any communicable disease, health condition, or syndrome in a community, institution, or region, or two or more cases of a communicable disease, health condition, or syndrome in patients with a common exposure. So this is a pretty general definition of an outbreak, and that is how Utah defines an outbreak. So basically an outbreak is one or two or more linked cases, but finding the common exposure there can be the challenging part. Therefore, it's important to have some background of your facility's rates. So in the absence of national benchmark standards for long-term care settings, determining whether there is an outbreak draws upon the routine surveillance data. And here is a hypothetical case. This is a graph that shows the new cases of C. diff infection in a nursing home X in May. There are 100 residents in this nursing home, and you can see that the baseline, this nursing home experiences 1 to 2 cases a week, so that would be the baseline. And so 1 to 2 new cases a week. And then you can see a spike in new cases around days 9 to 12. So do those patients have a common exposure? Could those cases be linked? And in that case, you would consider an outbreak.
So I'm going to talk a little bit about antibiotic stewardship. As we know, antibiotic use is associated with C. diff. It's one of the causative factors. And so it's important to make sure that you're treating an infection and not colonization. And this is something that is seen, unfortunately, pretty commonly in healthcare. We see a small change, we run a urinalysis, and that patient is colonized. They don't have an active infection, but they get treated anyway. And studies have shown that actually up to 75% of antibiotics that are prescribed in nursing homes are unnecessary or inappropriate. So you want to develop an antibiotic stewardship plan. The CDC has designed one that's a great template for long-term care facilities, and you can get that from their website. Some of the components of it are to review your antibiotics, make sure that you're using antibiotics that are appropriate, checking to your culture results and comparing those with what has been ordered, and having an interdisciplinary team. In regards to antibiotic use in C. diff, there actually has been a change in the guidelines for what's recommended to treat C. diff, and this came out earlier this year. You can read the full guideline from the Infectious Disease Society of America, but the recommendation is to treat C. diff with either vancomycin or fidaxomicin, and you can see we have the doses in the schedule available for you on our slide. Flagyl is no longer the recommended treatment. It can be used for an initial episode of non-severe C. diff only, but it's really not recommended. In our facility, we recommend vancomycin first and then fidaxomicin second. The reason why is the cost difference. Fidaxomicin is quite expensive, although it is shown to be effective in treating C. diff. The problem happens where you may say, okay, we've treated this patient with multiple courses of vancomycin. What do we do now? And the recommendation is to move to a fecal stool transplant, or an FMT. Those are recommended after 2 failed cases of antibiotic treatment. And you can work with area hospitals or outpatient clinics to transfer, send your patients out for those if you're not able to do it within your own facility. So now you've determined that you've got an outbreak. What do you do? The first thing that we recommend is notifying your local health department. And your health department has some great resources that can help you determine if you really do have an outbreak. It can help make sure you're following all of the protocols for managing that and knowing when that outbreak is resolved. You want to conduct surveillance daily, and the reason why is you want to capture new cases as soon as possible. So you don't want to be doing maybe a weekly surveillance and then realize, oh, this is getting out of hand more than we realized. And a big part of that is going to be working with your floor nursing staff and having them identify symptomatic residents and notifying you so that you can be on top of that. When you've identified new cases, create a line list, and that line list will have the resident's name, their room number, the date that their symptoms started, what symptoms they've had, and when their symptoms resolve, and that will help you track your outbreak. You want to make sure that you're following strict isolation practices so that you can control and contain it and it's not going to be spread as easily. And then if things are not really resolving very well or you're not able to manage the outbreak, you may need to consider restricting new admissions to the affected units. And I know that is a sensitive topic when it comes to your admission staff and your administration because they don't want to say no to admissions. But you may have to do that in order to get it contained and avoid spreading it to more patients. So in our facility, we had an experience where we were seeing an increased risk of C. diff in our facility. So I'm the infection preventionist, and in 2016, we were meeting together as a team, and I told our team that we had had an increase in C. diff, and I couldn't really pinpoint why. We felt like we were doing everything that we were supposed to in regards to contact precautions, using bleach to clean the environment, washing with soap and water, all of those things. And our committee decided that we needed to look and see if there was any other common denominators we could find. And just as an FYI, our infection prevention committee includes representatives from administration, nursing, infection prevention, physicians, physical therapy, pharmacy, respiratory therapy, environmental services, central supply, and our dietitian. We have found a great success with having that type of collaborative because each different discipline brings something unique to the table and has a different viewpoint of infection prevention. So we conducted a root cause analysis to determine what may be causing our increased rates, and we decided that most of our residents or patients that were getting C. diff had a history of IV antibiotic use. In our facility, we see quite a few acute patients and that do get a lot of IVs, and so we've decided to focus on this. Our dietitian did research and found a probiotic that is yeast-based. It's called Saccharomyces boulardii, and recommended that we do a trial on one of our floors so that any patient that was on IV antibiotics gets this probiotic, Saccharomyces boulardii, during their antibiotic therapy, and then for 14 days after the antibiotic has been discontinued. And we started to see success on our LTAC unit and then implemented that facility-wide, which led to a 65% decrease in our healthcare-acquired C. diff infections for both LTAC and skilled nursing patients.
So how can public health help? The Utah Department of Health HAI program can provide assistance with facilitating communication between acute care and long-term care facilities. We are finding that we're identifying transmission loops, and we're finding that all of the facilities are connected. Patient goes from an acute care hospital into long-term care often, and there is a link to the Utah interfacility transfer form.
Okay.
And we encourage use of the communication. One facility can't work alone. Everyone has to work together on this. We can provide facility visits and infection control assessments. These are consultative, not punitive, and we can help you with your infection control, and often just observing we can give you some advice on that. And outbreak support, we are there to help, and we provide education and resource materials. And local health departments as well. Reach out to them and see what resources they can provide. And here is the HAI program contact information for all 4 states included in this webinar. I noticed that the Nevada HAI program coordinator is on this call, Kamisha Causey. There's the contact information for you. And questions. I can certainly answer questions about public health. I also have Dr. Nakashima from the Utah Department of Health here, and Randon Bruniger for support. And then Lisa can certainly answer questions about facility issues.
So at this time, if you have any questions for our presenters, please go ahead and type those into the chat, and our chat master will relay those for us. One question from our multi-state lead for the nursing home work is, are the outbreak, guidelines the same across states, or is the one that you presented in today's presentation, is that just for Utah? Do you know?
I just know that that is the Utah communicable disease rule. Do you know?
So most states have strong HAI programs now, and will have that service available through their health department.
Okay. So it sounds like it could possibly vary depending on the state.
Yes, it does. But like I said, most health departments have been funded by the Centers for Disease Control to have HAI programs now, and so they usually have epidemiologists on staff to support.
Okay. Any other questions at this time, Shannon?
I'm not seeing any questions entered at the moment in chat, but we still have a few minutes, so please go ahead, folks. If you came here with the question today, let us know, or you can also click on the icon to raise your hand in order to be able to participate. If you look at your participant, if you click on the participants, there's an opportunity there for you to click on raise hand in that section. And Donna chatted in that it was difficult to hear the prior speaker that was talking a little bit about responses by state. So would she be able to repeat her answer?
Yes. Oh, yeah, just say it. Each state has their own HAI program, and the guidelines may differ slightly, but mostly be pretty similar. Was that okay?
Yeah, this is Ellen Akashima. Just to respond to that, I think that most programs throughout the country now, most states have been funded by the Centers for Disease Control to now have epidemiologists specializing in supporting healthcare-associated infection outbreaks. So I think that in individual states, you can go to your state health department and they should be able to refer you if you need that kind of help.
Thank you.
Thank you. While we're still waiting for questions, I'll just point out they listed several resources and references for you all to refer back to, and we will have these in a Word document, so you'll be able to refer back to them on our website. So there's 2 pages of resources, and then just our resources for the nursing home quality improvement work. There's ARC that some of you are familiar with. They have an antimicrobial stewardship guide. NHSN, for those of you who are using it. If you aren't using it and you would like to use it to track your infections in your facility, you are welcome to start. And then, as usual, you can find our recordings and handouts on our website as well. And Shannon will put the link to our website in the chat for you. Any other questions? Sorry.
Oh, there was a question about if there was an opportunity for a copy of the slides and so I just wanted to mention to everybody that what we'll do following this is in about a week or so, the video and slides will be posted on our website so you can view them.
Okay, thanks so much, Shannon.
Something that I will mention really quickly too, I didn't mention this earlier in my presentation, but I realized that in long-term care facilities, one of the major barriers to managing an outbreak can be shared rooms, shared equipment, shared bathrooms, things like that. And obviously in a perfect world, you would have all of your residents in a private room, but that's not usually an option in long-term care. So what I would recommend doing is if a private room is not possible, try to cohort someone with a history of C. diff, but avoid cohorting them with someone that has a history of other illnesses or risk factors. It's not recommended to cohort them with someone who has a multi-drug resistant organism like MRSA. In our facility, we created a form that the nursing staff completes anytime they're unable to place someone that requires precautions in a private room, and it goes through all of the risk factors, or on the other hand, any factors that would help limit the spread of infection, like if someone is bedbound or they don't use a toilet, things like that. And then our IDT reviews it, and it has to be signed off by infection prevention before we allow those people to share a room.
Wonderful. We do have a question in the chat, which is from Jerry, who asks, how do you get doctors on board with the antibiotic stewardship? This seems to be one of our issues with some of the doctors.
So I think it depends on what their specific issue is. In our facility, I track the antibiotics that are prescribed and I compare them against the culture results and their the patient's symptoms, and then I report that back. And once I had a baseline and could show, okay, based on your prescribing practices and these labs, X% of your patients maybe didn't need an antibiotic, that was helpful. I think it can also be helpful to get your medical director involved and have them assist with giving that education to the physicians, since sometimes they prefer that to come from a physician rather from a nurse or a layperson within the facility. And then also having your administration to back you up and say, yes, this is a priority. This is something we need you to get on board with.
Okay, anything else, Shannon?
Nothing else. I just wanted to piggyback on Jerry's question to say that the Agency for Healthcare Research and Quality's Antimicrobial Stewardship Toolkits actually have some really nice tracking resources. So that might be a place to start if you were looking for a tool. And I'm going to post our evaluation in our chat today for folks to be able to fill out. Oh, I'm sorry. So Jerry, what I just mentioned was there is an antimicrobial stewardship toolkit from the Agency for Healthcare Research and Quality that might provide you some tracking tools if you don't have them internally for your organization. You're welcome.
Okay, any last comments from our presenters at all? Questions, comments? If not, we'll move on. So on the screen here, you'll see announcements about events coming up soon. There's trauma-informed care next week. Then in August, we'll have a panel on pain management, and that is across several states that participate in quality improvement. We'll also have learning session 6. You'll have in-person sessions with your state leads, and then there's the virtual event on August 30th.
And Shylettera, I'm sorry, we did have another question about, is there time to address more about the daily surveillance?
Yeah, so what I do in our facility, if I'm tracking something daily, is at the beginning of the day when I come into work, we use an electronic charting system, so I log into that and look for any indications of a new case. But then I also go and talk to the floor staff and ask them if there's any of their residents that are showing the symptoms that we're watching for, if they've had any changes that I need to know about, and then that is all documented daily. And depending on your outbreak, you may be needing to do that multiple times a day, or ideally just getting your staff in the habit of notifying you if anything changes and they do have a new resident that's become symptomatic. And then as your outbreak resolves, you don't need to keep doing that daily if you don't have the resources available. I realize that can be pretty time intensive. You can go back to doing more of your routine surveillance. The daily surveillance is to capture your new cases, make sure that they're being isolated appropriately, the appropriate treatment has started, and help track the size of your outbreak.
Okay, thank you so much, Lisa. Anything else, Shannon?
I am not seeing any additional questions in the chat. We've probably got about 30 more seconds if anybody has something that is really on their mind.
Yes, so just that last page of announcements, and you'll be able to find all of these on our website. We have 2 trainings coming up that are specific to this topic at the end of August. There's a presentation about appropriate prescribing, and then there will also be in the spring training for infection preventionists by the CDC and CMS. So look for those. This is just where to find us online. Again, NHSN is there if you want to start tracking your own infections in your facilities. Look for the link for the evaluation in the chat. Our contact information, one more time, know where to find us. And if you have questions for our presenters today, please reach out to your state leads and they'd be happy to follow up on those things for you. And with that, we will end. Thanks, everyone. And thank you to our presenters, Maureen and Lisa. Thank you so much.
Thanks.